quickly give a very fast appraisal of what.
You have 1 minute, Dr. Lomi. So
What choroidal melanoma, what
have
all
to
you can
speak.
do it. Yeah. Next slide is not working. Yeah. So choroidal melanoma, how can you diagnose it? Basically, the patient comes with incidentally. You can check during the routine ophthalmoscopy, during fundus examination, and also the patient comes with blurred visual acuity, the paracentral scotoma, or progressive loss of the vision, and sometimes comes with the floaters. So in next slides we'll go quickly about the diagnosis and the management. So in clinical features, when we see a dome-shaped mass, choroidal mass, which may be pigmented, non-pigmented, when you see a mushroom, that means that it has gone through breaks through the Brooks membrane and then come internally. And then it may be associated with retinal detachment, exudative retinal detachment. So one of the important diagnoses here is you do ultrasound, this A and B scan ultrasound. So here you see a very characteristic features with mild to moderate amplitude spikes because of homogeneity of the mass. And then you have got a very steep angle capacity, the steep decay of the internal reflectivity, and you have got a choroidal excavation and acoustic syndrome. So this is a very typical sign of a case of choroidal melanoma. And others are fundus fluorescence angiography, where you can find some differential diagnosis difficulty with choroidal hemangioma and all. So here we have early hypofluorescence and a late hyperfluorescence. Another is the OCT. You can see a serious retinal detachment with a debris on the back of the retina with normal thickness retina. And sometimes MRI is another important imaging tool, like for looking for extra ocular growth and also the optic nerve involvement, where you find a hypo-intense in T2 weighted images and then hyper-intense in T1 weighted images. PET-CT scan is another important tool to rule out any distant metastasis, where you find the liver is the most common area where you can find metastasis. So it's very important to rule out any systemic metastasis before you carry on with your management. Sometimes you find a very atypical presentation where you need to do a final aspiration cytology, where you have to take into account the risks versus the potential benefit of this FNSC, like in case of diffuse choroidal melanoma, or in very young children where you find a choroidal mass like this, or very anteriorly located mass, and sometimes a case of amylotic choroidal lesion. So I'll skip this video. We can do it FNSC and then with a 2-port pass planner, and then you can find it cytology also here. So what all can be done when you diagnose a case of choroidal melanoma? So there are various determining factors, like depend upon size, location, and extent of tumors, the visual status of the affected eyes and the fellow, the age and general condition of patient, and most important, the patient's consent, and then the motivation to retain the globes. So there's various treatment strategies, like for small, medium, and large. Small melanoma we can observe, or we can do the transplant thermotherapy, and then medium we can randomize into plaque brachytherapy or combined plaque brachytherapy with TTT, or we can do a gamma knife therapy. And for large, you can either go for enucleation, or you can do this external beam radiotherapy like a gamma knife. So for small, we usually consider for the apical thickness of less than 3 millimeter. You can go for transpapillary thermotherapy. It's an infrared radiation that gives a thermal effect and cause apoptosis to cells. The plaque brachytherapy is one of the most common these modalities which we usually use now. Either you can use the Retain 106 or the iodine 125. For Retain 106, the apical thickness is less than 5 millimeter, and then for iodine it should be less than 10 millimeter. Where you can identify the location, you can place a plaque with a radiation dose around 70 to 100 gray, and the treatment duration will be around 5 to 8 days. So this is the result of one case with after 9 months post-plaque brachytherapy.
I think Lomi will have to conclude. Yeah.
So another indication, gamma knife therapy, and then this is how you do the gamma knife therapy. And For last, irrespective of whatever treatment of modalities you choose, patient need a careful observation for years, and initially 3 monthly you can do, and if there is no change, then 6 monthly, or if growth of or any defect, you can consider for any further management, and yearly PET scan whole body may be helpful for early detection of distant metastasis. Thank you.
Thank you, and thank you for your patient hearing, and my apologies to Dr. Neeraj and his team for extending on to their